Good morning.
Hello. Good
Hi.
evening.
Oh, good evening for you. Yes.
Yes. Here it's evening, ma'am.
Sorry
So
about that. How are you?
yeah, I'm fine. Thank you, ma'am. You could join in time. We are so happy.
Happy to join. Sorry, my light in here is not very good.
It's okay. It's clear, ma'am. So we may start maybe after 10 minutes. Our first
Okay.
speaker, yeah, he's yet to join due to some unavoidable problem. So he had just contact us. He will be joining within 10 minutes. And
Okay.
yeah, sure, ma'am.
I'm here. I'll turn my video off for now.
Okay. So it's early morning, no, ma'am? In your
Yes, it is
place.
early morning.
Yeah, I know.
A little dark. You received the slides?
Pardon, ma'am?
You received the slides I just sent by WhatsApp?
Oh, I think so. Our coordinator, I think they might have received. Yeah, I'll just inquire.
Yes, ma'am. Yes, ma'am. This
Mm.
is one of the organizers speaking. Ma'am, actually right now in India, especially Mizoram, we're running into a little bit of a network problem. So that is why some of our speakers are also having some connectivity issue. And the
Yeah.
slides you sent, we are trying to download it. Right now, the connectivity is
It's
really
not very
not
good.
up to the not up
Okay,
to the
no
mark. So
worries.
we apologize.
I can control from my end as well. So if that's easier, I can do it from here.
Okay.
Oh, okay, ma'am.
Mm.
I'll get back to you on that. Let's hope that we can, download it. And anyway, there's a slight problem. Everyone is having some connectivity problem. They're just,
Yeah.
just hope. Keep our fingers crossed that it will be solved within the next 5 minutes or so. Let's
Okay.
hope.
Okay.
Oh. Hello, ma'am. Can you hear, Carrie, ma'am?
Yes. Can you
Okay,
hear me?
as yeah, other speakers hasn't joined yet. Would you like to start first? As
Sure. And I can share my slides.
yeah, sure. So then I will start the webinar. Okay. Then
Okay.
yeah, fine. Thank you so much, ma'am. Already 56 of us are there.
Okay.
On behalf of the principal and webinar organizing committee, Mizoram College of Nursing, I welcome the respected resource persons and esteemed participants of this webinar. Thank you for joining us for today's webinar. I'm Helendal Tianglimi Sailo, Senior Lecturer, Mizoram College of Nursing, and I will be the moderator for this webinar. So today's theme for the webinar is Infection Control, Saving Lives Through Prevention. So this is the fourth webinar conducted by this institute. We are very grateful to our principal for her guidance and able leadership for the success of this webinar. So we have three subtopics today. The first topic is Breaking the Pandemic Chain, and the speaker for this will be Dr. Sanjay Bhattacharya, Senior Consultant, Department of Microbiology, Tata Medical Center, Kolkata. And the second topic is Challenges for Healthcare Workers During the Pandemic, and it will be taken by Dr. Carrie Tudor, TB Project Director, International Council of Nurses. And the last topic is Role of a Nurse in Infection Control During COVID-19 Pandemic. And the speaker will be Mrs. Belinda A Sawant, Director of Nursing Services, Saifee Hospital, Mumbai. I apologize for our principal as she could not join the webinar in time due to connectivity issues. She will be joining us later on. I would like to make few announcements. If any of the participants has any questions, make sure to type your questions in the chat box. After completion of each subtopic, we request the speaker to answer the questions. And at the end of the webinar, a feedback form link will be shared in the chat box. So kindly give your feedback of the webinar and your certificate will be sent to the respective email ID. So please make sure that you type the correct email ID. So now we will start with the first presentation. The first topic for tonight's webinar is Challenges for Healthcare Workers During the Pandemic. And the speaker will be Dr. Carrie Tudor. Dr. Carrie Tudor has worked in global health for nearly 20 years. She has completed PhD from Johns Hopkins University, and following her PhD, she completed Fogarty Global Health Postdoctoral Research Fellowship based at Covet in Durban, South Africa. She has published several articles on infection, prevention and control, and occupational TB in healthcare workers. Dr. Tudor is currently the TB Project Director for the International Council of Nurses, ICN, working to build the capacity of nurses related to TB, MDR TB, and patient care in China, Russia, and 6 sub-Saharan African countries. So I now request Dr. Tudor to speak on challenges for healthcare workers
Thank you
during
very
the
much.
pandemic.
Thank you very much. Good evening to all of you there in India. I'm talking to you from Texas in the United States. So I'm very happy to be with you virtually. And today this evening, I'll speak to you about some of the challenges for healthcare workers during this COVID pandemic. So just a brief outline of the talk today, just to start off with how COVID started, how it spread, what are some of the concerns for healthcare workers, the current challenges, and maybe some implications for the future. So first, I felt that it was important to go back to where we started in Wuhan, China. Of course, the first few cases were from the wet market in Wuhan back in late November, December of last year, so almost a year ago. but then in early January, Dr. Wen Liang, he alerted his colleagues that there was this strange pneumonia that they were seeing, and basically alerted the world, but sadly, he also succumbed to the disease in early February. And so there's been a lot of press, obviously, about SARS-CoV-2 and COVID-19 and how that is affecting the healthcare workers and the healthcare industry. Many, and it's taken over all of our lives this year. This, I just want to show a graphic of how fast the virus really started to spread and how at the time, and we're a little bit less panicked now, but back in, if we can think back to January and February, how scary it was that this virus was spreading around the world so quickly, and we really didn't have a lot of information about it, how it was spreading. We had some ideas, and we have a better picture now, how to treat it, how to diagnose it, how to care for patients that that had COVID virus. And this graph will only go up until about April. So, but it is kind of scary to see it in a graphic form like this, at how fast it really spread across the world. And it will be over in a second when we get to April. And I'll just, for time, I can move on. But we can definitely see that Asia and Europe and Latin America were greatly affected. Whoops. And then just another graph here of cumulative cases from the start of the outbreak to present day. The green line at the top is the United States here, and we're just at 11.3 million cases. India is the orange line below, just below, in second place. Need to find my mouse again. And at 8.9 million cases, and then Brazil is this red line at 5.8 million cases. So again, these are cumulative cases, and I know that in the United States, and it looks like India, are experiencing similar issues of another, in Europe as well, of another spike in cases as we get into the cooler part of the year. So some groups are trying to collect data on the reported cases of COVID among healthcare workers globally. And I tried putting this map together from various different resources, from an article that's in pre-publication now. The International Council of Nurses has collected some data and released some of that survey data. They surveyed 50 national nurses associations and prepared a report that they released for Patient Safety Day back in September. Amnesty International is looking at this as well, among other numerous research studies. And this is what I could compile. It's by no means complete or accurate. Some data is only presented through May, June of this year, and so hasn't really included anything since then. But the big thing that I want to point out is that there's very little, you can see big parts of the world where there's very little data presented, and how ICN and other groups are calling for WHO and countries to collect surveillance data and to collect proper data on healthcare workers as it relates to cases of COVID and, of course, deaths. But as of August of this year, ICN, from data from 44 countries, an average of 10% of all COVID infections across the countries that responded, 10% were in healthcare workers. And at that time, from the data they collected from countries, there were 1,500 nurses who had died of COVID, but ICN is estimating that that number may be as high as 20,000 worldwide, and that's just nurses, not including doctors and other healthcare workers. So we have a long way to go in how we improve the data that we collect on the surveillance of disease in healthcare workers. And we see a similar issue for working in TB. We see similar issues for TB, that data on disease in healthcare workers is not very well reported. So if we talk about some of the challenges, which are many, and again, in the early stages, I think many of us were in a panic about what to do. We don't always get very good training as nurses on the emergence of a new pandemic and crisis preparedness. There was I think in many parts of the world, I was living in Africa at the time, and a lack of information to some extent, or we just didn't know enough about the virus. Many different, a lot of information or effort was spent on surface decontamination, because we thought that was the main driver of the virus. Others felt that it was airborne from the beginning. WHO has maintained that it's mostly droplet, and still WHO focuses very much on surface disinfectant. And those of us working in airborne disease have been pushing that it's airborne, and more data is becoming clear that the surface contamination is a less effective mode of transmission of the disease. So mostly droplets or airborne aerosols. But I think those of us in the healthcare industry also lacked clear guidance early on, how to identify patients with symptoms, how to protect ourselves, and how to treat patients. And especially, at least in the United States, there was a big issue with diagnostics, and I'm sure that that's happened in other countries as well, as to which tests should be used. Different tests give different results. Now we're finding the antigen test is good if you're within a few days of symptom onset and have active symptoms. But if you're asymptomatic, the antigen test is the same as flipping a coin. And so then if you're asymptomatic, then you need to use the PCR test. So there's a lot of things that we're still trying to learn about the virus. And coming from a TB background and infection control, I know that in many parts of the world, China, for example, in South Africa, that the TB wards were turned into COVID wards, because TB is where the airborne infection control was, or better isolation rooms or isolation techniques were better in TB wards. So TB nurses kind of, in some places, had to bear the brunt of housing and holding COVID patients, often with a lack of extra training. And then we had the global shortage of PPE, gloves, gowns, goggles, everything, but especially respirators and masks that we're still suffering from. And then we had the challenge of countries developing their own plans and response and guidance to the pandemic. And even at the global level, part of that was, at what point do we call it a pandemic versus an epidemic? Politics always play a role, unfortunately. And I know in India and other countries where you had national lockdowns, where the idea was to help mitigate the transmission, but also cause such great hardship for especially the lower income migratory populations and our lower income day laborers and others who can't afford to be off work for a month at a time, and how for them, the situation was kind of a life or death. If I don't work, I don't eat. And there's many people had a lack of food or other support during those lockdown times that made it difficult for them to actually enforce, in many places, to enforce lockdowns because people needed livelihood. And so that, instead of helping to mitigate the transmission, the disease continued to spread. Many places have failed to implement good contact tracing. I know in South Africa, they did door-to-door campaigns, screening everyone in the households, especially in slum-like areas. They went door-to-door, screening people, whole families, trying to isolate those who had a fever or showing signs and symptoms, putting them in a hospital for isolation, for quarantine for 2 weeks, to some success. But at least they were doing testing. So South Africa, at least their testing data is pretty accurate. But again, it was really hard, especially in the slum areas, to isolate people and stop transmission. But in the United States, contact tracing has not worked very well at all. And I would be happy to hear from you in India how contact tracing has gone there. And again, coming from TB, we do a lot of contact tracing in TB. We know that from working in TB or with other airborne infectious diseases that infection prevention and control in a lot of places comes down to hand hygiene to varying degrees, but there's often poor airborne infection control in most places, or lack of ability to separate patients. So that has been a big challenge, I think, globally. And for those of us in TB, it's something that we talk about all the time. And now with COVID, it's finally getting the global level of attention that it deserves. Buy-in from the public, I don't know about India, but in the United States, there are high-level politicians, including our soon-to-be ex-president, who refuses to wear a mask, doesn't want to wear a mask. It's limits for political reasons. People think that wearing a mask is somehow limiting their freedom. So if you're in one political party, you don't wear a mask. If you're in another political party, you wear a mask. And so it's, I don't know if you've had similar issues in India, but it's been quite an issue here. So if we can't get the public to buy into the public health messages and to follow good practices of wearing a mask to protect themselves, but to also protect others in the community, especially those at high risk, how do we prevent the disease? We have healthcare workers, nurses, doctors going on TV and social media all the time here in the US, begging people to wear a mask, to not much success. So I am interested to see how that's worked in India. So without buy-in from the public and I guess support from the political leaders, these are other challenges that we're going to face because we won't be able to get the virus under with the mental and emotional burnout. And again, social media around the world has shown nurses crying after hard days of losing many patients in despair. We've seen numerous nurses, especially in Italy, at the height of the epidemic in Italy and Iran, nurses committing suicide after working in the ICUs and with the surge of the epidemic, which is tragic, and we don't want that to see that. I know in many countries, nurses and other healthcare workers won't go home to their families because they're worried about bringing the infection or virus back to their family, so they stay away from their children or their parents or their spouses living separately, and that takes also an emotional toll. We've had cases of nurses and healthcare workers experiencing stigma. People on the street see that you're a healthcare worker and they kind of shun you, push you away, or spit on. There have been healthcare workers who've been spit on and people telling them, don't get close to me. So all of these things are quite difficult to deal with. And the other issue, and I'm not interested to hear from an India perspective, I know other countries that this has become a big issue, whether or not the country's Department of Labor recognizes COVID as an occupational disease, so that healthcare workers, if you do develop COVID-19 on the job, if you're able to get any compensation for your disease, and if you have time off. I mean, there have been issues in some countries, even the United States, that a healthcare worker will test positive for COVID, but is expected to still go back to work, when ideally that person would then have to be on quarantine for 2 weeks until the time has passed and then come back to work. And so that's been a huge issue in many parts of the world. But we do want to make sure that, I guess, lobby departments of labor or ministries of health to ensure that healthcare workers can receive compensation for an occupational disease and get paid time off while they have to be in quarantine or while they're recovering from their illness. So how do we address these many challenges? And first and foremost, at least for me, and this is kind of my area of research, is that we need to make sure that all healthcare workers are able to work in a safe environment, and that's free of injury, free of exposure to disease. And unfortunately, as healthcare workers, there'll always be some exposure of disease, but how we can protect healthcare workers so that there's minimal risk of contracting any disease. A large part of that comes back to infection control, and I know you have an infection control speaker later, so I'll keep that short. Again, compensation and paid leave if a healthcare worker becomes sick with COVID while working with TB as well. In many parts of the world, occupational health programs for healthcare workers are limited, better in other countries than in some. But going forward, there has to be some sort of way to systematically screen and test healthcare workers for COVID, TB, or any other illness that comes around. Now that we have a COVID vaccine or several potential COVID vaccines on the horizon, we need occupational health systems that can help to vaccinate our healthcare workers. Normally that is usually hepatitis B for now, but how are we going to vaccinate large numbers of healthcare workers in a short period of time? And ICN and WHO are definitely pushing that healthcare workers be the first to receive new COVID vaccines. Training is always important, not just on infection control, but also for healthcare workers to know what their rights are, especially as they relate to occupational health compensation. But how do we protect ourselves? How do we protect others? And also getting training on the disease in question, especially as more and more is known about it. And again, as I mentioned, the surveillance of disease and injury in staff and healthcare workers is also very important going forward, so that we can address issues as they come up. So some implications for the future, from my perspective, is that there needs to be better global and national government commitment, not just to healthcare, but for pandemic preparedness. How do we respond to a crisis like the one that we are facing now? And some countries have risen to that challenge better than others. But I think it's important that we all know this in the back of our heads, that we need to be prepared. And again, pushing or supporting the notion that COVID is an airborne disease or droplet. Airborne infection control is often sidelined for, in hospitals, we often tend to think about surgical site infections, other hospital-acquired infections, hand hygiene and things like that, but not thinking about the infections that might be hanging in the air. And so to refocus more attention on that. But we know there'll be another pandemic at some point. We just don't know when, and we don't know where, and whether it's a full global pandemic or a regional epidemic or outbreak. We know it's going to happen. So we just need to make sure that we're always prepared. And I think COVID has given us some good lessons to learn from. I think there needs to be some, and I don't have the answer on how to do this, but some global agreement between countries, either from a WHO or UN perspective, or I don't know, again, how to do it, but to ensure that there's an adequate global production of PPE so that not everything is made in China or in India and there's a global pandemic, and because everyone is on lockdown, nothing gets created, and then the world is at a loss of PPE, like we saw with this pandemic, that most of it was made in China. China goes into lockdown, there's no global production of PPE. So how do we ensure going forward that there's either a global stockpile or enough production in different parts of the world that we don't see that same shortage going forward? Again, improving infection control, but you have someone talking about that next. Budgeting for occupational health and infection control and just health in general, especially human resources. Most countries don't have a separate budget for infection control. So for PPE and other things, there's not a separate budget. And so it's up to either hospital directors to decide how much of the hospital funding goes to PPE. So I think it's an opportunity for nursing associations at the national level to lobby governments that there needs to be some sort of dedicated budget for PPE specifically, but also staff compensation for and paid leave if anyone gets sick, training, but actual having dedicated human resources working on infection control and occupational health issues. And again, coming back to better surveillance, healthcare workers, I don't know if you have this saying in India, but we say canary in a coal mine, that they would often send a canary bird into a coal mine. And if the bird died, they would know that there was an issue with either toxic gas or lack of oxygen. And healthcare workers, and we are kind of the canary in the coal mine, that if we start getting sick through work, that it's an indication that there's a problem maybe within the facility, within healthcare. And so we do need to do a better job of surveillance so that we can identify problems before, like Dr. Li Wenliang from China, that he got sick and healthcare workers got sick early on, that we need to act. So thank you very much for your attention, and I'm happy to take any questions. Oh, and these are some materials on infection control that I chair an infection control group, and these are some of the materials that we've developed on respiratory protection, respiratory fit testing, and upper room germicidal UV. And we've done a lot of work with the National Institute of TB and Respiratory Diseases in New Delhi. So thank you very much.
Thank you very much, ma'am. We are very happy for you being over here. Any questions? Now I invite from the participants. Any questions we have, please drop it in the chat box. Any questions from the group?
Ma'am, I have a question. I'll just say it over here. Uh, um, because it's very important for, for when we were talking about scarcity of PPEs and these things. So as nurses, as nursing associations, like how do we go about improve, or how do we go about like lobbying for better budgetary or administratorial changes regarding this these problems?
Thank you for your question. That's a very good question. I know, and I think this comes down to the surveillance of disease in healthcare workers as well. It can be very powerful for you to be able to go to your Ministry of Health, either at the national or regional level, to say, we've had so many nurses develop COVID-19, so many nurses have died. And this is due to a lack of equipment, or we're unable to protect ourselves. I know in China, this picture behind me, my background picture, these nurses in China, it took the nursing director of this hospital 3 years to get these N95 respirators for these nurses. And so it's this is the first day that they were able to get their respirators and wear them on a TB, drug-resistant TB unit. And it took the nursing director, having gone through training, knowing that she needed that everyone in the hospital should have access to N95s. It took her 3 years of tracking down the hospital director and badgering him, 3 years. But she finally had to do a cost-benefit analysis to show that this is how much N95s are going to cost, because the response always was, it's too expensive, it's too expensive. Let the nurses get sick, or doctors, or whoever gets sick, and then we'll pay for their treatment and time off. So she did a cost-benefit analysis of, this is how much respirators will cost, and this is how much we'll save from having people off sick and treatment and everything else. And so he finally consented, and here they are with their respirators.
Okay.
So I think it comes down to being able to have data to back up your argument, which I think in times of COVID, we have plenty of data. But I think that in China anyway, it ended up being a cost-benefit analysis that finally got it. But I think also being able to show the toll that it's taking may be helpful as well. And it may take some fighting, or fighting is the wrong word, but it may take some encouragement over a long period of time.
Okay, thank you, ma'am. That is interesting and informative. Thank you very much.
You're welcome.
There is one question. How important is a negative pressure isolation room for management of COVID patients?
That's a very good question. Without an easy answer, we find that in a lot of places, negative pressure rooms require a lot of maintenance to ensure that they're actually working properly. It does help, but we are also finding that having people, the infected person, wear a mask and others wear either a respirator or mask, can drastically reduce transmission. So it's not necessary to have negative pressure. It also depends on the treatment that the patient is getting. For aerosol generating procedures, you may want someone in a negative pressure room. But again, it's important for the healthcare workers to have higher level of protection, goggles and respirators for aerosol generating procedures. But just the nature of being in a negative pressure room by itself isn't necessary. It can be helpful, but it's not necessary.
Okay.
As long as people are appropriately masked.
Thank you very much, ma'am. Another question. How important is eye protection? Are the relative risk of eye exposure same as nose or mouth exposure?
I know that in the United States anyway, they're saying that it's important for healthcare workers to wear some eye protection, but I haven't seen any data, and I doubt that it exists, to show exactly how much of transmission is through eyes, droplets getting into the eyes, and how much of it is through the respiratory tract. My guess is that the majority of it would be through the respiratory tract, but it's a very good question. And again, nose and mouth always need to be covered with a mask, or a respirator. So I don't think we have good data on the eye thing, but I think it's just saying to cover the eyes to be better protected. But I don't have any data on what percentage of transmission is happening through eye contact.
Thank you so much, ma'am. Any other questions? I think that's all the questions. We are very happy, ma'am. Thank you so much for covering challenges for health workers and how to address those issues. I know that the problems which we face over there and over here, even in India, state to state, the problems are differ. So thank you very much. And this is an eye-opener, ma'am, for our future preparation. Thank you so much.
Thank you.
May I just have one second, Helen?
Yes, hi,
Yes,
how are
yes,
you?
Hello, nice meeting you.
Nice to see you as well.
Yeah, and I'm happy to see you and to know that you are safe and sound. Thank you so much for, thank you so much for accepting our invitation.
My pleasure. Thank you for inviting me.
Thank you so much. We had a nice time, nice session, very good session. Thank you.
Thank you.
Okay, now we'll go over to the second topic, challenges for healthcare, breaking the pandemic chain. So we will turn the time over to our speaker, Dr. Sanjay Bhattacharya. He is MD, DNB, FRC, PAT, CCT UK, working as senior consultant in microbiology department at Tata Medical Center, Kolkata. He had more than 100 publications, including 9 book chapters, and has wide experience. Currently, he is the chairperson of Hospital Infection Control Committee at TMC, and also WHO working group on the following: priority pathogen list, environment cleaning in carba-resistant organism, landscape of diagnostic against antimicrobial resistance in LMIC, and also he is ICMR working group on bacteriology, SOP, antimicrobial policy, and also NCDC working group on infection control guidelines. So I invite Dr. Sanjay Bhattacharya to deliver his speech. Yes, sir.
Okay, thank you, everybody. And I'm sorry for being late for the first presentation, but it gave me a wonderful opportunity to listen to the speaker, the previous speaker, and I learned a lot from that presentation. So thank you for inviting. I will go into the talk, and I would request the hosts of the Zoom to actually change the slides for me, if that is possible. And can I have the first slide, please, which is a title slide, that is breaking the pandemic chain. And we will see how the pandemic chain can potentially be broken. And but before we do that, we are going to see certain basic aspects of COVID. So next slide, please. So as we know that the COVID is a disease which is caused by a virus which is called SARS coronavirus type 2. And after an exposure, it is not always the case that you would have an infection. So an exposure may not translate into an infection, but some exposures, particularly those which are considered high-risk exposures, do lead to infections. Now, this infection can both be asymptomatic as well as symptomatic infections. So as we are seeing during the course of the pandemic, that there are many infections which are detected in people who are either having minimal symptom or practically no symptoms. And these asymptomatic infections are being detected in patients who are actually being screened for COVID before a major procedure, which could be a surgery, which could be chemotherapy, which could be a transplantation, things like that, or even endoscopy. So in symptomatic infection, you have essentially three types: the mildly symptomatic ones, the moderate symptoms, and the severe symptoms. And most of the infections, fortunately, do resolve. So as far as we know, that 80% of the infections do not require hospitalization, about 20% require hospitalization, and depending upon the geographical region, country, healthcare, we have a variable death rate, which is around 1 to 5% in most countries. So this is what is the entire schematic of COVID. There is an element of antibody which is generated. There is also evidence that cell-mediated immunity also plays a part both in the pathogenesis of the disease as well as in protection. But the time will tell us to what extent the antibody-mediated immunity or the cell-mediated immunity would be protective or otherwise. Next slide, please. So this is a schematic representation of the type of cells which interact with the COVID virus or SARS coronavirus type 2. And you have the involvement, although the primary interaction occurs in the alveolar epithelial cells, but once the infection is established, there is inflammation. And as a result of inflammation, various immunological cells actually come to the site of infection in the lungs. And these include the neutrophils, the NK cells, the T cells, the monocytes, the macrophages, and the type 2 pneumocytes. So these actually interactions which occur following infection and inflammation lead to generation of cytokines. And depending upon the degree of cytokine that is generated, one would have a spectrum of disease. Essentially, if the cytokine generation is less, you may have little symptoms, whereas if the cytokine generation is substantial, you may have very severe disease. Next slide, please. So looking at the various modalities one need to tackle in order to break the chain of transmission of COVID, one can see there is the infectious agent, which is the SARS coronavirus type 2. So one has to tackle that. But this infectious agent, because it's a virus, it is an obligate intracellular parasite. And so that it requires the reservoir, which is an infected person who could be symptomatic or maybe asymptomatic. Now, the virus exits the body through several routes. So there is the portal of exit, and the portal of exit of the virus could be the nose or the mouth through the salivary secretions or the nasal secretions, but it could also be the gastrointestinal tract through the stool, it could be through the tears, and that is the means of transmission. The virus is transmitted in a variety of different ways, not only from the respiratory tract, but also it has been shown that the viral particles are present in tears, and the virus in the viable format is also present in stool samples. Now, once the virus escapes from the infected individual, it has to enter into a susceptible person. Now, it is not that if 100 people are exposed, all 100 will have the infection, because the body, as you know, has got an innate immunity as well as an acquired immunity. And this immunity plays a very important role in restricting the virus from establishment of the infection, or even in which cases that the infection actually is established from manifestations of signs and symptoms. So the portal of entry, as we have seen, is mostly the respiratory tract. It enters through the nose and mouth and goes into the respiratory tract. But as we were seeing in the previous session's question and answers, that the eye could be a route of entry of the virus, and we will see that why the eye could be the source of entry of the virus. And this is how the chain of infection actually works. Next slide, please. Next slide, please. So in order to break the chain of transmission, one needs to kill the pathogen. That may be easier said than done. Prevent contact, prevent its escape, prevent transmission, block the ports or the ports of exit and entry, and develop some sort of resistance in the host. So these are the different ways in which the virus transmission could be prevented and the chain of transmission could be broken. Next slide, please. So as we know that there is a concept called flattening the curve. And one of the strategies that are used actually to manage epidemics and pandemics is to flatten the curve. So what is actually flattening the curve? So it is using a variety of different infection control measures. So be it through the use of PPE, be it through social distancing, be it through environmental disinfection, be it through isolation and quarantine. You have these measures which will actually reduce the number of cases that develop in unit time. So if you have a reduction in the number of cases per week, per day, per month, then the health system would be able to actually cope with this surge of cases. Because it is very difficult for the health system to cope, be it in terms of the number of doctors, number of nurses, number of beds, number of ventilators. These are very difficult to cope if the number of cases that are coming to the hospital is enormous. So a variety of different infection control measures like social distancing, like use of PPE, like early diagnosis, treatment, like early detection of cases and isolation of cases, these are actually applied to flatten the curve and reduce the transmission. So this graph actually shows that without protective measures, you will have a certain number of cases and which may exceed your healthcare system's capacity. So it may exceed your hospital's capacity in a particular geographical region to cope with it, either in terms of resources or which could be manpower, which could be nursing, the number of nurses that are available, number of doctors that are available, etc., etc. And if you apply the infection control measures, then the cases do occur. And it may so happen that the same number of cases would occur. But because it is occurring over a protracted period of time, the health system can cope with it. So that's about flattening the curve. Next slide, please. Now, how do we kill the pathogen? And the pathogen, as we know, is a SARS coronavirus type 2, which is an RNA virus. And it is actually something which is highly infectious that we have understood. Now, there are several strategies actually to kill the virus. But before you can kill it effectively, you have to know that the infection actually exists. So the early diagnosis, isolation of infected patients, and institution of appropriate treatment are very, very important actually to contain the pathogen and kill the pathogen. So now we have heard about various drugs which are used for the treatment of this infection. Now, most of these drugs that are there are actually repurposed drugs. So what it means is that these drugs have been used for a variety of different infections in the past, and some of them may not even be antibiotics. They are being reused for a different indication, and in this case, for the management of COVID. Now, remdesivir and favipiravir are two specific antivirals, but at least for remdesivir, we can say that it is a drug which have been previously used for the treatment of Ebola virus infection. Likewise, ivermectin has been used in a variety of parasitic infections. Doxycycline has been used in bacterial infections, and hydroxychloroquine has been used again as an antimalarial. So these are not unique drugs. These are not drugs which have been developed in the last few months for COVID. So it would be appropriate to describe them as repurposed drugs, which had certain indications before the advent of COVID, and they are being reused for a different indication because either in vitro models in the test tube, or in animal models, or in certain experimental settings, and sometimes in clinical settings, they are being seen to have an effect on the COVID virus or in the outcome of the disease. Now, in addition to the specific antivirals, there are other agents which are also used for the treatment of COVID, and these are nonetheless, these are not less important. So you have oxygenation of the patient, adequate hydration, nutrition, and you have supplementation with micronutrients and vitamins like vitamin D and C and zinc. And you have the use of various immune modulators like the use of steroids such as dexamethasone, as well as physical therapies like respiratory physiotherapy, early mobilization, etc. Now, these are very, very important for the management of the COVID patients because, to be fair, there are very few specific antivirals which have, without any controversy, shown unequivocal benefit in treating COVID patients. So we are still not there. So we are largely using supportive measures to support the patient and to boost immunity and get the patient better. So that's what we are doing. Next slide, please. Yeah, so this is a figure which actually looks very complicated. The disease is also complicated. I would not like to make the matters more complicated for you. You can have the slides and you can give it a go and understand the details. What it essentially means is that the virus has a certain type of life cycle. And in an established infection, that life cycle exists, and that you can see at the left upper corner of this figure. Now, once the virus is in a position to enter the cells, all viruses need a receptor to enter. So what you see at the lower left corner is a receptor, which is the ACE receptor or angiotensin converting enzyme receptors. And you have variety of time periods from day 0 to day 2 to day 5 to day 7, where different events occur in the course of the infection. There are different types of receptors involved, one of them being the toll-like receptors. which are also involved in complement activation. And what you can see that on the right-hand side of this figure is that different types of cytokines are generated in patients, particularly who are severely unwell and in the later phases of infection. And these include things like interleukin 1, interleukin 6, interleukin 8, and others. So, and interleukin, yes, and these play a very important role in actually the pathogenesis, the signs and symptoms of the disease, and the outcome. So the virus infection occurs, and that leads to a series of events within the cell, and as a result of which inflammation occurs, and the inflammation triggers various cytokines to be generated, which leads to signs and symptoms. Some of them are used for prognostic applications and detection, like the interleukin 6, and also as therapeutic targets, and also determine the prognosis of the patient. Next slide, please. So the early diagnosis of COVID is another part of breaking the chain of infection. And as we can see from this slide, that there are various ways in which you can actually diagnose SARS-CoV-2 in a clinical diagnostic laboratory. Now, the most important method, obviously, is the RT-PCR, or the real-time PCR. And these may be conducted either in the conventional format, which takes probably about 6 hours to complete, or it may be done quickly within an hour by a cartridge-based nucleic acid amplification test, such as the GeneXpert. Now, there are also some cartridge-based format, as for example, the BioFire from a company called Biomedical, or QIAstat from a company from QIAGEN, where you may test COVID along with other viruses as an entire spectrum of respiratory pathogens, which includes not only the SARS-CoV-2 virus causing COVID, but also influenza viruses A and B, parainfluenza viruses, and all that causes the respiratory syndrome. Obviously, those panel-based tests are more expensive, and they may not be always available with all the hospitals. The antigen detection tests are good in terms of specificity, but they have a lower sensitivity than the PCR-based tests. And these are also available in the traditional ELISA-based format or in the rapid antigen test format when they are called RATs as immunochromatographic tests. Now, there are other molecular tests which are not PCR-based tests, which are available in the global market and currently in the Indian market also. And one of the examples of that is the Abbott ID Now test, which can give you a result in about 15 minutes. So they are also pretty sensitive, like the PCR-based tests. They are also more sensitive than the antigen-based test. They may not be as sensitive as an RT-PCR test, but they would certainly detect more cases than the antigen detection tests. Next slide, please. Now, this graph actually shows you that what happens to the antibody response and what happens to the virus in the course of the illness. So there is an incubation period, which we think is close to 5 or 6 days. And there is a period in which the virus is most likely to be found. And that is generally 2 days prior to the onset of symptoms in symptomatic individuals. And it lasts for about a week or so, maybe at the most about 9 or 10 days, in which you can actually culture the live virus if you have the facility of a viral culture, which is only there in reference laboratories, which are recognized by the ICMR. Now, that is not to say that the virus would not be detected through an RNA-based test even after that. So the PCR may continue to be positive for a longer period of time, often about a month or so. And but detection of the virus by PCR does not necessarily mean that the patient continues to be infectious. As you know, in most places in India, people are advised to remain in isolation for about 17 days from the time of the onset of symptoms, or in case of asymptomatic infection, 17 days from the time of PCR positivity. And this 17 days comes from the fact that you are expected to remain asymptomatic before coming out of isolation for about 10 days. And the virus is probably active for the first 7 days of infection. Now, those places which are doing antibody tests, the antibody tests are actually essentially for serosurveillance to detect infection in the community and not for diagnostic purposes. So they are more for research. And you have two types of antibodies, the IgM and the IgG antibodies. And obviously the IgM will come first and disappear first, and the IgG will last for some period of time. Now, whether the IgGs denote protection or not, that's another question, and we will try to deal with it when we deal with the question of vaccination. Next slide, please. Now, this is a slide which actually shows the comparison of the three types of tests: the RT-PCR-based test, which detects a viral RNA, the antigen-based test, which detects the viral antigen, and the serological test, which detects the antibodies against the SARS-CoV-2 virus, be it of the IgG type or the IgM type, or a combination of IgG and IgM type. And obviously, the samples are different for the antigen-based test and the PCR-based test. You take a nose and throat swab. And the antigen-based test, particularly if it's a rapid test, could be done within a very short period of time. The RT-PCR test, the conventional format, as I said, can be done within a working day, about 6 to 8 hours, whereas the rapid RT-PCR tests can be done within a very short period of time, about an hour or so. The serological test takes minutes. It may take about an hour or so to do. And depending upon, but the serological tests are not actually for diagnostic use at the moment. So what does a positive test indicate? The positive test detects viral RNA for an RT-PCR based test, but does not indicate whether a viable virus, a live virus is there or not. As I said, that the RNA-based test could remain positive even when the period of infectivity is over. The virus surface protein is detected in case of the antigen-based test, and the antibody-based tests are indicative of past exposure to the virus. Next slide, please. So one of the ways of breaking the chain of COVID-19 is actually social distancing. And these are some examples of social distancing which WHO's, this slide actually shows. So somebody deciding to work from home. The online classes, which are very common for students, is a classical example of social distancing, as well as things like the virtual meeting that we are having now is a very good example of social distancing. Otherwise, I would be coming to Mizoram actually to have a dinner and have the talk in your presence. And also very important to note that the social distancing is also happening in the healthcare in the form of teleconsultation. So there are many, many examples of social distancing, and it's very important we keep a distance of at least a meter, preferably 2 meters, while we are actually seeing each other. Next slide, please. Now, one has to remember that in a hospital, if you have the facility and if the patient is actually coughing or going to have an aerosol generating procedure, then it's preferable to have the patient in a negative pressure isolation room. Now, airway suctioning is an example of an aerosol generating procedure. If the patient, let's say, is going to have some sort of endoscopy, it could be aerosol generating procedure. If the patient has a BiPAP based ventilation, it could be aerosol generating. So these are certain examples of aerosol generating procedures in which a negative pressure isolation room would be ideal. And these isolation rooms are special because they have a separate ventilation arrangement. They are at a pressure of minus 30 pascals compared to the corridor, and they have ensuite facilities, so an attached bathroom, and they would have an anteroom for changes for people to actually, so the healthcare workers to change, wear the PPE and discard the PPE when they come out of it. So this diagram actually shows the difference between a normal pressure side room, which is at isobaric pressure, and a negative pressure isolation room. And you can see a negative pressure isolation room has double the air changes per hour. So ACH is the air changes per hour. It has 12 air changes per hour compared to a standard room, which has 6 air changes per hour. So next slide, please. Now, if one is dealing with an extremely infectious patient, and that is true for all infections which are airborne, so like tuberculosis, measles, chickenpox, and other contagious diseases which is transmitted through the airborne route, and COVID is the SARS coronavirus type 2 is showing signs that it could be airborne in certain cases, certainly. So there you need special type of wards. Now this is an idealized diagram where you have all the facilities in the world. So you have the patient room, which is described here as the bedroom of the patient. You have an ensuite facility, and you have the airlock facilities through which you can actually enter and exit the place. You have a dirty utility to keep the dirty linen and other dirty instruments of the patient. You have a staff change area, and you have actually airlock facilities in between for patients or visitors or staff to enter into that particular area, taking obviously adequate precautions. So this is an idealized version, and it's as it shows, it can be very, very expensive, resource intensive, and expensive to establish and maintain such an isolation facility for patients who are highly infectious through the airborne route. Next slide, please. So this is another diagram which shows that the design of a negative pressure isolation room, and you have a bedroom which is at minus 30 pascals. You have an anteroom which is at less negative pressure. You have an ensuite facility at the toilets which are at the same pascals. So the idea is that the infectious materials from the ensuite facility or in the patient room should not escape into the exterior. So that's why you have kept them at the negative pressure relative to the corridor and the exterior. Next slide, please. So there was a question regarding eye protection and COVID. Now, I personally think that the eye protection is important. Not that I have done some research into it, but from my understanding of the literature, eye protection is important, and it could be either through goggles, particularly in the aerosol generating procedures, or by a face shield in non-aerosol generating procedure where you're approaching a COVID patient. And the reasons for eye protection are the following. One is that the surface area of the conjunctiva has been measured, and it is not less compared to the surface area of the nose, or it is substantial proportion of the surface area of the mouth, of the mucous membrane of the mouth. So the conjunctiva, if you look at the palpebral conjunctiva as well as the the other part of the conjunctiva, they have a significant surface area, and particularly if you count that of both the eyes, it is significant. The second important point to realize is that the nasolacrimal duct. So if the virus goes into the eye, then there is a duct from both the eyes which goes into the nose, and this is a nasolacrimal duct. And so the virus can theoretically enter through the tears, through the nasolacrimal duct from the eyes to the nose and create an infection. The third reason why the eye protection is very important is that you have the ACE2 receptors on the conjunctiva. So these are the receptors for the COVID virus, and they have been found on the surface of the conjunctiva. And the eye is not just a portal of entry, but it could also be a portal of exit. So if you're wearing a goggles, you are not only protecting yourself, but in case you already have the infection, you are actually preventing its transmission to the exterior, because the tears have been found to have the COVID virus in persons who are infected with COVID. Next slide, please. Now, wearing a mask is important. There is no doubt about that. But wearing the right type of mask is perhaps more important, and wearing it properly is as important as anything else. So this is a schematic diagram which shows the various layers of the mask. And you can see that a properly designed mask has many, many layers. And if you take, so forget about the ventilator fan over there, and we are not encouraging the use of valve masks. So if you forget about that, so there is an outer layer of the mask which is made up of non-woven polypropylene fabric. And there is an inner layer of mask, which is again made up of non-woven polypropylene fabrics. Whereas there is the filter layer, which is made up of melt-blown fabrics. And there is a supportive layer, which is made up of mono acrylic fabric. So, or more acrylic fabrics. So you can see that the designing of the mask is very, very important. And studies have shown that if you are just wearing a cotton mask, or let's say a surgical mask, it will not provide an adequate protection. The picture on the right-hand side shows an electron microscopic picture of a proper mask. And a mask is not just a net, it is actually a sort like a forest. So in a forest, you know that it's very difficult to get something through a forest, although the gaps between the trees are quite substantial. The reason is that there is not just one layer of trees, there are multiple layers of trees in a forest. And so is the case of a properly designed mask. And because there are so many layers which are crisscrossing each other and zigzagging each other, it becomes very difficult for any particle and even a virus to escape through the mask. So having a mask is important, having a properly designed mask is important, and wearing the mask consistently and properly is even more important. Next slide, please. So now I'm coming to the last part of the presentation, which is on the viral vaccines. And there is a lot of word about the vaccines in the news media as well as in the scientific literature. Now, this is a general schematic representation of the type of vaccines. So virus vaccines can be either inactivated vaccines, which are killed vaccines, or they could be weakened vaccine, and the term used for weakened is attenuated vaccines. And but these vaccines can also be used through a viral vector, like an adenovirus vector, which could be a replicating adenovirus vector or a non-replicating vector. So similarly, you may decide that instead of using an inactivated virus or instead of using an attenuated virus, you are going to use not the virus, but the DNA or the RNA of the virus, and in this case of the Covert, the RNA of the virus. So it could be a nucleic acid vaccine. And lastly, one could have a protein-based vaccine. So the protein-based vaccine could be a subunit of the vaccine, or you can create an artificial assemblage of protein when you call it a virus-like particle. So to cut a long story short, you have various types of vaccines, and you can use the delivery vehicle as the virus as such, or you can use another virus when it is called a viral vector, such as the adenovirus. You can either use proteins or nucleic acids as your vaccine components. Next slide, please. So this is a table which shows the various types of vaccines that are being experimented in various phases of clinical trials. And the ones which are towards the lower half of this table, they are all being made in China and developed in China, and the research is happening in China. So, and the ones which are at the upper part of the table are in the Western world. So you have, for example, the University of Oxford vaccine, and the University of Oxford is working in collaboration with AstraZeneca. And the vaccine that the University of Oxford is trying to develop and standardize, and the clinical trial is happening, is an adenovirus vaccine. So that's an example of that, and it is in the phase 3 part of the study. Whereas Pfizer is trying to prepare a vaccine, which is an mRNA vaccine. These are very crucial examples of that, of the mRNA vaccine. And so is Moderna, the company called Moderna, and NIAID, the US organization, and they are also trying to develop an mRNA vaccine. So from this list, we can see that not all vaccines are the same. There are mRNA vaccines. There are also certain DNA vaccines which may, which are being trialed, and there are adenovirus which are being trialed, and there are inactivated vaccines, particularly the vaccines are the inactivated vaccines. Next slide, please. Next slide, please. So you have heard about the Russian Sputnik 5 COVID vaccine, that this was the world's first COVID vaccine which came into clinical use. Now, this is actually an adenovirus vaccine, and there are 2 types of adenovirus that is used. And there is a first vaccination at, let's say, at day 0. And about 21 days or 3 weeks later, there is a second vaccine which is given as a booster. So this is an example of an adenovirus vaccine, of a sequential vaccination to boost the immunity, both the antibody immunity or perhaps an element of the cell-mediated immunity as well. So this is some of the details of the Russian Sputnik COVID vaccine. Next slide, please. So this is my last slide. So in order to answer the question, what can we do to break the chain of infection? I think it is important to realize that the role of each one of us, whatever may be our position in the community, or whatever may be our designation within the hospital and job description, each and every one of us have got a responsibility towards the prevention and control of COVID. And when I think about the types of preventative measures to break the chain of transmission, one has to go through the basics once again. And it does not, it's not rocket science for a majority of them, but it is very, very essential we may or may not have, hopefully we will have an effective COVID vaccine, but that's the technological part. What is at our hands and which can play a very important role in prevention of the disease and prevention of transmission of this infection are standard precautions. And standard precautions, as you know, is hand hygiene, appropriate use of PPE, appropriate disposal of biomedical waste, environmental cleaning and disinfection, respiratory hygiene and cough etiquette. There is a need for social distancing, use of mask appropriately, so the right mask at the right time in the right manner, and education and training has to be continuous. And I am thankful to the College of Nursing at MIzoram for organizing this webinar, because it is actually playing a very important role in actually spreading the message of infection across the country and perhaps in the wider world. Vaccination would be there, but it will take time to manufacture all these millions of doses of vaccine and administer them to a significant part of the population. Timely testing and treatment is as important as anything else. So is isolation, quarantine, and vaccination. So when I was actually preparing the slide, I was thinking of putting an yes or no against the doctors or nurses or health administrators, other healthcare workers or general public. And then I realized that everyone is important. And actually, it is very difficult to say no to any of these tasks for any of the professionals. So my last message is that each and every one of us has got a role to play in the prevention and control of SARS-CoV-2 or COVID. And yes, we certainly should work together and make it a reality to break the chain of infection. Thank you for your time and patience and opportunity for giving me this wonderful time to present my understanding about COVID before you. And I'm happy to take any questions.
Thank you very much, sir. It is an excellent lecture. You have completed everything within a short period, very, very clearly. So there is one question from Mrs. Silo. Recent articles have said that many people in Pulwama, Jammu and Kashmir have developed COVID antibodies, though they are not known to be COVID positive. What can be the reason for this? What is the present status of COVID vaccine development worldwide?
Okay, so the status of COVID vaccine development worldwide, as I have tried to show it in a table, is that the vaccination is not an easy process. And you know that most vaccines, first it starts from the drawing board, and then in the in vitro experiments, then the experiments in laboratory animals. So there is a preclinical part of the development. And then one enters into a clinical trial, which has got phase 1, phase 2, and phase 3 clinical trials. And the phase 1 are generally on tens of volunteers. The phase 2 may be on a few hundred volunteers, not more than that. And the phase 3 are on thousands of, several hundreds, if not thousands of people in which it is tried. Now, there are probably about 3 or 4 vaccines which are in the advanced phase of development. And these are the vaccines from Moderna, from Pfizer, from Oxford, University of Oxford, in collaboration with AstraZeneca, the Sputnik vaccines, and maybe one of the Chinese vaccines. So if you look at these 5 types of vaccines, most of them are either in phase 2 or phase 3, which are at an advanced stage. So that is the answer to the later part of the question. I could not follow really the first part of the question. If you can repeat it, I can answer.
Yes, I'll just repeat, sir. Okay. Recent articles have said that many people in Pulwama, Jammu and Kashmir have developed COVID antibodies, though they are not known to be COVID positive. what can be the reason for this?
Okay, I've got it. So it's a report from Pulwama in Jammu and Kashmir. So that may occur because of a variety of reasons. So you have an antibody positive, but PCR negative situation. And the reason most likely is that they have an asymptomatic, they have had an asymptomatic COVID infection in the past. And when they have tested for their antibody, that asymptomatic infection has cleared, or they may even have had an asymptomatic infection in the past. So at the time of testing for antibodies, they are no longer carrying the active virus. So they are RNA PCR negative, but antibody positive. So this is the explanation for that.
Okay. Thank you, sir. Sir, there is one more question. Is there any reason to believe that COVID virus is biogenetically engineered, as said by some conspiracy theory?
Okay. I am not a detective, so I cannot be very certain about it. What I think, I have gone through this question before, and what I have understood from the literature is that there are, I can tell you what people think about it or what the experts think about it. Don't count me as an expert in this particular question. So there are actually 3 or 4 theories. Theory number 1, which I think is probably the closest to the reality, is that it is not any conspiracy. It is actually a naturally evolved pandemic. Okay. And it is probably the COVID-like viruses, other coronaviruses are present not just in humans, but also in animals. And sometimes what happens because of genetic changes and because the interaction between humans and animals are becoming quite intense because we are doing deforestation, we are eating up some of the animals, we are taking over the territory of the animals, bringing live animals to the market. So somehow the animals, because of animal viruses, because of certain genetic changes, may cross the species barrier and start causing infection in the humans. And because it's a new virus for the humans, it may not be a new virus for the animals, then humans would not have a substantial immunity. And that's how a local outbreak starts, which develops into an epidemic, and then it develops into a pandemic. There are 2 other theories that whether it is an accidental release and whether it is deliberate release. I don't think there is any actually evidence to support any of these. So I am personally more of a believer of the natural evolution hypothesis of this virus.
Okay, thank you, sir. Sir, another question. Is there any difference in efficacy between ear loop N95 mask and around head N95 mask?
So difference in efficacy between N95 mask and?
Ear loop N95 mask and around head N95 mask.
Okay, so one mask is around the ear, another mask is around the head. Okay, I did not never thought about this question, but as you asked me this question, I think what is important is the mask fits your head and covers your nose and mouth appropriately. So whatever is fitting you properly, with a band around your ear or around your head, it's not important, it has to fit. So if it does not fit, even if it is covering your head, it is not going to work. So the fit testing of an N95 mask is as important. So some people, they wear the mask very casually. Okay, so sometimes it is just underneath the nose. Sometimes it is even underneath the mouth. Now, what is the point of using that mask? I don't understand. It's a mask, as far as I understand, it's still not an object of fashion. So you don't wear a mask to show that how beautiful you are. You are actually wearing a mask to protect yourself. So wearing the mask, right mask, consistently in the right way, of the right quality is very, very important.
Thank you very much, sir. So, sir, there are more questions, but as there is limited time, so I may request we may send those questions to you personally for answering later on.
Okay, thank you for your opportunity and time given for a patient hearing.
Thank you very much. Thank you very much, sir, for your excellent class. Thank you very much. So, the last topic for today's webinar is role of a nurse in infection control during COVID-19 pandemic. And the last speaker for today's webinar is Mrs. Belinda A Sawant, Director of Nursing Services, Saifee Hospital, Mumbai. And Mrs. Belinda has completed MSc Nursing and is currently pursuing PhD. She has a total of 25 years of experience in teaching, clinical, and administration, and worked at various esteemed institutions and hospitals. She has contributed to nursing profession through various ways as an ISO editor, organizer, and speaker at national and international level. And also, she has various publications in nursing journals and co-author on the section of cardiovascular system, textbook on medical surgical nursing, a nursing process approach. Now I request Mrs. Belinda A Sawant to deliver a lecture. Yes, ma'am.
Thank you. And thank you for inviting me to be a speaker on this in this esteemed webinar. Am I clear?
We can hear, ma'am.
Yes. And good evening to all the participants who are on the webinar. And without wasting much time, I will go on to the topic which I will be speaking on. So I'll share my PPT. Can you see the PPT?
Yes, clear, ma'am.
Yes. So I'm going to speak about the role of nurse in infection control during COVID-19 pandemic. So just to break up the topic and to understand what we as nurses have been doing and can do in this pandemic era, I've just broken down the processes right from triage, that is from the time the patient enters the hospital till the patient leaves the hospital and goes home safely. So as we know, triage is basically sorting out patients when they come to us. So it is early identification, prevention, and treatment. So as you see on the screen, for triaging the patients who come with COVID-19, we have to maintain certain precautions. As you see that we have to have a well-ventilated area. There should be a dedicated area. The patients who come with respiratory symptoms should be wearing a mask. There should be distancing of at least 1 meter between two patients. There should be use of sanitizer. The family members are usually not allowed to accompany the patient. They are kept in a separate area so that there is no transmission of infection as far as possible. There has to be no overcrowding. There has to be rapid assessment that takes place for these patients. So these are the few precautions, or these are the few preventive measures that we can take care in the triage area. Another thing is, once the patient is diagnosed or has come with a diagnosis of COVID or is suspected to have COVID, there has to be a unidirectional flow for patient to go into the identified ward or the area where they are supposed to be admitted. Now, as we have heard the previous speakers speaking about standard precautions and additional precautions, so here without wasting much time or without even thinking about it, all of us have to follow the standard precautions, right from hand hygiene, before and after patient contact, use of personal protective equipments, safe and use and safe disposal of sharps, performing routine environmental cleaning, cleaning of medical equipments that are being used, following respiratory hygiene and cough etiquette is very important for these patients or in this situation. I'm sure we all must have seen various videos and learned cough ethics after so many years, and also about using aseptic technique and handling and disposing of waste in a safe manner. So these are the standard precautions that we have to use. We have heard from the previous speakers, or by now we all are aware that basically COVID or the virus is transmitted by through contact and through surfaces, and of course the droplet infection. So here we have to follow hand hygiene practices as per WHO, the 5 moments of hand hygiene practices, which we can see over here, and how to use a hand rub solution or how to wash the hands following the 7 steps of hand hygiene, the 5 moments of hand hygiene. So all these need to be learned and need to be implemented and practiced in the right fashion. Now coming to personal protective equipments, we have heard about the protective equipments from our earlier speaker. Basically, we as nurses, to prevent infection or to curtail infection, we have to ensure that the PPs that we use are based on patient care setting, activity, and the risk that is involved. So depending on whether it is an indirect caregiver or whether it is a direct caregiver, you have to use the PPs appropriately. So right from face mask to an N95 mask to a face shield to goggles to gown to disposable aprons if you are wearing a cloth apron, gloves, head cover, shoe cover. These are the main PPs that are being used by healthcare workers, by nurses, doctors, housekeeping staff who are right in the forefront taking care of COVID patients. So this is how we select on the PPs, and there are a few principles that we need to keep in mind when using PPs. That is, perform hand hygiene before and after um, uh, performing hand hygiene before and after. The PP that we have should be easily available, and it should be available depending on the risk that is involved and in the correct size. We have to put the PP before coming in contact with the patient, remove the PP immediately after completing a task or leaving the patient area. Never reuse disposable PP. That is what we need to keep in mind. And we can clean and disinfect reusable PP between as recommended. But out of all the PPs that we usually can disinfect is the goggles, which we have to wash with soap and water, and then we disinfect with 70% of alcohol. Next few principles are PPs should be changed immediately if they are soiled or contaminated or damaged. Okay, do not adjust or try to touch your face, when you are in the midst of caring patients. Uh, if there's a concern or there's a breach of any of these practices, it's better to leave the patient care area and remove and change the PP. And always remove PPs carefully to avoid self-contamination. That is very important, from the dirtiest to the cleanest area of your body. So this is how, these are the few principles we need to keep in mind. We need to practice these principles whenever we are donning and doffing the PP. I'm sure by now most of us know the sequence of donning PP. So the sequence of donning PP is you wash your hands, you wear the shoe cover, you wear the coverall, you wear your N95 mask, you wear your goggles, and you wear your gloves. So this is how you don into a PP. Coming to doffing of PP. Kindly remember that doffing of PP is of primemost importance, because when you doff or when you take off your PP, you are taking away a cover or a protection from your body, which has protected you when taking care of COVID patients. So just like in the operation theater, when we take away our surgical attire, we take it away from our body. The same principle should be kept in mind when you're doffing of the PP. So as I said, from the dirtiest to the cleanest area, so you again wash your hands, you remove your coverall, you remove your shoe cover, you remove your goggles, you take away the gloves, you wear another pair of clean gloves and take away the N95 mask. Please remember, this is mainly by droplet is a droplet borne disease and also an airborne bone disease. So you have to be very careful when you're taking off your N95 mask. So you have to actually lower your head forward, bend your head forward, loosen the strings around on the back of your neck, and take the mask away from your face and put it directly into the bin. And then of course you wash your hands and you take a shower before you leave the area. Now all these PPs, whichever you are doffing or taking off, should be immediately put into the bin, the color-coded bin, that is into your red bin, red color-coded bin. Of course, the N95 mask goes into the yellow color-coded bin. So this is what you have to take care when doffing. It is very, very, very important to doff off very carefully, because this is an area where you can contract infection if you do not take care. Now, from standard precautions, in addition to the standard precautions which we carry on for every patient, we also have to follow your contact precautions, droplet and airborne infections. So as you see in contact precautions, you have to hand hygiene, gown, gloves, and cleaning of the equipment after every use. In addition to contact precautions, droplet precautions are almost the same. What is additional is mask with eye protection. And for airborne infections, which we have heard earlier, is the N95 mask. You have to have a well-ventilated room where you're taking care of your patients or coverting your patients, preferably negative pressure, but it should be a well-ventilated room, and cleaning of equipment after every use. So these are the additional precautions that we have to follow. Now, I'm sure most of the hospitals practice, and it happens also in our hospital, where we do not allow the relative or the family member to be in the COVID ward along with the patient. So no relative or no family member can come without the permission into a COVID area without taking any additional precautions. Now, once you have triaged your patient and you have identified whether it is a confirmed or suspected case, in every hospital or every area or every healthcare setup, there should be a separate unit for confirmed and suspected cases. We cannot keep confirmed and suspected patients in the same area. So there should be a separate unit. There should be dedicated routes or paths for patient movement, staff movement, and for your contaminated items or linens, whatever you're using for your patient. They have to be different zones which can be demarcated in the ward or in the area. That is a clean zone, intermediate zone, and contaminated zone, as we have seen in the previous slide. Of course, the focus is on natural ventilation with airflow of at least 60 liters per second, and negative pressure rooms with at least 12 air exchanges, which we have seen in the previous slide. So these are the few principles we need to keep in mind when we are planning for the infrastructure or movement of patient or placement of patients. So this is just a layout which we have seen in the previous slide, but this is a very simple layout. So depending on the infrastructure of your hospital or what best you can do for your patient safety and staff safety, we can divide the area basically into clean zone, contaminated zone, and intermediate zone. So just this is where the staff enters from. Then will be your room where the staff can have have the tea or tea room or for drinking water. In some hospitals, the bathroom or the locker room is adjacent to the PP donning area. This may be the admin block, where maybe your clean utility room, where you prepare the medicines or you keep your stocks and your stores so that it is not it doesn't get contaminated. So this could be a clean area. And once the PP is done, you enter into the contaminated area where your patients are being placed. After taking care of your patient, then you come to the doffing area. In some hall, this is a layout where they have got outer doffing area and inner doffing area. So some hospitals may just have one doffing area where the entire PP is being removed and is being disposed of safely. Once the healthcare worker doffs the PP, then they wash their hands, they go to the wash basin, they have to take a shower and then leave the floor or the ward. So this is a very simple layout, okay, which speaks about a clean zone, a contaminated zone, and the intermediate zone. Another point which I would like to highlight is your additional control measures, which speaks about hierarchy of controls. So hierarchy of controls in COVID-19, okay. So if you see this diagram, from bottom to top, from bottom is least effective to most effective at the topmost. So what we see over here, we are harping so much on PP, but let me tell you, in this pandemic, though it is said to be least effective, It is of course important, and it plays a very important role in contracting the healthcare workers with COVID infection. So PPE, as I have mentioned earlier, it should be easily available, the right size, depending on the risk that the healthcare worker is involved in. We have to protect each and every worker with PPE. Administrative controls, which we'll see in the next slide, but basically it focuses on how you change the way the people work. So you change the working style, or make certain put certain strategies to help the people to work in a better fashion. Engineering controls is isolate people from hazard. So engineering controls, as we have seen in the earlier slide, it may be your infrastructure, it may be the use of bins or your hand dispensers where you do not have to touch on to. It may be, certain barricades that you put, or the demarcations that you do that people cannot go beyond a particular point. So these are the way how you can isolate people from the hazard. Substitution, we are still waiting for a effective vaccine, and we all pray that we get successful into it. So there's no substitution for COVID at the moment, but elimination, of course, that you try to be away from the hazard, that is you stay at home, you work from home. As the previous speaker rightly said, that probably we all would have been in Mizoram right now, which we are missing at the moment. Okay, so we conduct all our teaching sessions or webinars or conferences. So this is how we can reach this particular, that is the most effective control of elimination. So this is the hierarchy of controls which is applicable or which we are implementing in COVID-19. I spoke about administrative controls. So as nurse administrators or nurse leaders, okay, we have to be very much involved in preparing SOPs for COVID-19 management. Okay, so I'm sure most of the hospitals have done this, and whatever I'm talking is a part of our protocol which we are following an example in our hospital. So we have to have SOPs so that people understand, they know what process, how to follow, what to do. They do not get stuck, and we are able to manage our patients and our staffs in an appropriate manner. Training of all healthcare workers, whether it is a nurse, whether it is a doctor, whether it is a security at the entry of your hospital gate, they all need to be trained into how to take care of themselves, how to screen the patient, whether it may just be temperature checking at a point of entry. So training of all healthcare workers is very, very, very essential. Adequate patient to staff ratio. It is not just nurse to patient ratio, but also doctor to patient ratio, healthcare worker to staff patient ratio, because they need to work with a comfort level. Okay, they are wearing PPEs, they cannot wear the PPEs for maybe more than 6 hours. So duty scheduling, giving them adequate offs, giving them good compensation. So all this is important so that they can comfortably work in these COVID areas with lot of stress that goes back of their mind. So this is very important. Planning care, which I'm sure most of the nursing administrators must have also worked on it, or we all follow it. Minimal contact time or exposure. Okay, in our regular patients or the non-COVID patients, there are many activities that we do around the patient. Of course, we always emphasize that whenever you plan your activity, you plan it in such a way that you do not disturb your patient n number of times. You complete the activity, leave the room, on completion of your task. So here we have minimized the contact time or the exposure by instructing the nurses. Okay, what are the essential assessments they need to do and how they can complete it in one go, and so that they don't spend a lot of time with the patient. Providing immunity boosters, which we do in our hospital. We provide protein shake, we provide immunity boosters for the all the staffs working in the COVID ward. Surveillance process for identifying healthcare workers who are prone to develop COVID-19. So when they come on duty or they are having any signs and symptoms, then they are guided to the triage area, where again they are triaged or whatever necessary investigations to be done. So this is an ongoing process, and infection control nurse plays a very important role in surveillance of these healthcare workers. Creating awareness on importance of prompt medical awareness. Okay, most of the times we wait, right? We feel that COVID will not come to us, or we take a chance. But whenever we feel that we are unwell, then we need to seek for prompt medical attention. Monitoring healthcare workers' compliance with standard precaution and providing mechanisms for improvement. This again is constant auditing, on-site monitoring, or auditing and surveillance to see that whatever SOPs we have put in place, whether our healthcare workers are following it or no, and if they're not following it, then what measures we can put in place so that they follow it and they do not contract any infection. Next is environmental cleaning and disinfection. So a few general principles which we have heard earlier. Okay, so microorganisms are transferred from contaminated surfaces to patients and staffs via hands. So hand hygiene and cleaning and disinfection of environmental surfaces is very, very important. So what can we as nurses do? So when it comes to environment cleaning and disinfection, we have to remember basically there are two types of areas, high touch areas and low touch areas. So when you talk about high touch areas, which you can see in this picture, are your doorknobs, the bedside locker, the cardiac table, the bedside rails, your IV stand, your night lamps. So these, your curtains, edges of your curtains, okay? So these all are your call bells. These are all your high touch areas. So they need to be disinfected very frequently, maybe every 4 hourly, with 70% alcohol. And low touch areas are the ones where you do not, where your hands do not go on very frequently. For example, the ceilings, the walls. So these are the low touch areas, and these are disinfected with 1% sodium hypochlorite. Now these are the all the medical equipments that we use mainly for our patients with COVID-19, and most of the majority of the equipment that we use is your pulse oximeter, is all your oxygen devices, right from nasal cannula to a ventilator. So these all need to be disinfected after every patient use. Before leaving the patient unit, the nurse is responsible for disinfecting it with 70% alcohol and leaving the unit. So this is very, very essential, because if in a setup where you do not have individual, for example, pulse oximeter, then, and which you're using on n number of patients, you need to disinfect it once it is used on a patient and leave the room. So this is of prime importance. Coming to biomedical waste management. I'm sure we all have learned about biomedical waste management, and this stands true in COVID-19 too. So when we talk about biomedical waste management, we have to follow the rules of your local corporation, okay, because the color code probably may change from one state to another. But generally what we see is, okay, when we speak about biomedical waste management, what I would like to remember, it is not just disposal of the waste. It is, you are segregating the waste, you are disposing it in the right bin. For example, you may use a green or a black bag or a black bin for your domestic waste. Yellow bag is all your recyclable waste. Sorry, is not recyclable, is your cotton swabs or expired medicine. Blood bags can go in the yellow bag. Red bag is your recyclable waste. White bag, white is your sharps container, and blue is your glass waste. So this is how you can segregate. You have to dispose the waste. Then you have to label the waste is very, very important, because if in case you have to track it from where the wrong disposal has happened or segregation has happened. So it is very important. So labeling the waste, transporting the waste, storaging the waste is all of prime importance when it comes to biomedical waste management. What we have to remember is the COVID waste, that is, which is being stored in these bins, or the weighing scale which you are using to weigh your waste, because I'm sure most of the corporations or most of the hospitals, the waste that is generated is being weighed. So all this, your bins, your weighing scale, they need to be disinfected with sodium hypochlorite. And with 70% alcohol, that is, your weighing scale can be cleaned with 70% alcohol. So this is very important that you also disinfect the accessories that you're using for your waste management. Now, few considerations when you are taking care of obstetric patients who come to you, right? We cannot deny services to our special people. That is, a mother who wants to, a mother who is due for delivery, or a patient who is due for delivery. So preferably we admit them in a single room. Care of the newborn is very important. So once the baby is born, whether it is a LSCS or whether it is a normal delivery, the newborn has to be kept in the warmer at least 2 meters away from the OT table or from the delivery table. The baby should be cleaned prior shifting to the room with the mother. Baby swab test has to be done 24 hours after birth, but of course that can be consulted with the pediatrician. Some may not prefer it, some may prefer it, so that the choice is open. Keep the baby in the room at least 6 feet away from the mother and avoid close contact with the mother. Coming to breastfeeding, express breast milk should be given. There has to be a dedicated breast pump which needs to be which has to be used, and of course following good hand hygiene and hygienic practices prior to expressing the breast milk, which has to be fed to the which of course the nurse or the caregiver will feed the baby, and clean the breast pump after every use. So these are the few considerations we have to keep in mind when we take care of a newborn in a COVID type situation. Next is the OR management. In our hospital, we had incidences, or we had situations when we had to operate on COVID positive patients. So if you're operating on a COVID positive patient, then that operation theater, there should be minimum equipments, instruments and accessories. There should be minimum OR personnel in the OT, restrict movements of people or personnel in and out of the OR. You have to put out the AC 10 minutes prior to patient arrival in the operation theater. If the patient is going to be given general anesthesia, the anesthetist you should use hood for intubation and extubation. Once the surgery is done and the patient is extubated, the patient and the surgical team should remain in the OT for nearly 15 to 20 minutes. Following that, only the patient can be transported to the ward or to the ICU, wherever the patient has to be. Whether it is a COVID ICU or a COVID ward, the patient needs to be shifted there. And of course, minimize use of aerosol producing procedures, for example, your cauteries and suctioning. So these are the procedures that we should try to minimize. So these are the few considerations that we have to keep in mind if a patient who is COVID positive requires surgery. Now, care of the deceased body. I'm sure we have seen horrible videos where patients who die are not treated with respect and dignity. It's probably because of fear or probably lack of knowledge or no proper protocols. But over a period of time, people have understood what is COVID, and I'm sure that they are handling these dead bodies with respect and dignity, which is of utmost importance. Now, whenever you are packing the body, okay, the puncture size or wounds, if any, should be disinfected with 1% sodium hypochlorite. You have to wrap the body in a mortuary sheet, and of course, you can expose the face by covering the face with a face shield. Place the body in a leak-proof bag, which you can see over here. And externally, you can spray the bag with 1% sodium hypochlorite. Embalming of the body of COVID patients is not permitted. And if you are mobilizing this patient to the mortuary or to the ambulance, you have to disinfect after use with 1% sodium hypochlorite. So these are the few aspects we need to keep in mind. And of course, you have to coordinate with the local authorities or with the local burial places, how to manage these bodies and ensure that there is no transmission of infection to others. Next is, how do we again prevent or try to curtail the infection for patients who are already having COVID-19 is your nutrition and your immunity boosters. As I mentioned earlier, we not only provide immunity boosters or immunity drinks or foods to our staffs, but also to our patients. So it's a part of their meals that they have, that they get immunity drinks when they're hospitalized with us. And of course, this is the nutrition advice which I picked up from WHO, which says that we have to eat healthy food, drink plenty of water, preferably warm, eat healthy fruits, decrease your intake of sugar and salt, avoid eating food from outside, and seek medical help. So this is the nutrition advice for patients with COVID-19, which we as an organization, we circulate brochures or videos on how to manage at home after getting discharged from a hospital. So this is which I was talking about, post-discharge care. For ill people, as we have heard earlier, washing hands, very important. Staying at home, be safe, very important. Good food, nutrition, plenty of fluids. Staying in a separate room, well-ventilated room. I'm sure in an Indian scenario or in the city of Mumbai, okay, our houses are not very big, so we have many people staying in maybe in a single room. At least we should try to tell them to maintain 1 hand distance for the safety of them and safety of others. And of course, which I spoke to you about, is the cough etiquette, that you have to cough or sneeze in your flexed elbow, so that the organisms do not get transmitted onto others. Again, hand washing, very important. When to wash your hands, there's a list of when to wash your hands: after coughing, after sneezing, after touching, if you're handling something that is visibly dirty. So this is all about hand washing. How to protect others from getting sick. The same thing, your cough etiquette. If you're using tissue paper, put it in the bin. Again, hand washing. So if you see, all the emphasis is on hand hygiene, maintaining social distancing, wearing your mask. So these are the few points which we keep on harping for the prevention of COVID. If you have a travel history, of course now the rules are getting relaxed day by day, but travel history needs to be informed, and if any symptoms, then medical attention should be sought for. Again, the same about hand washing, which is emphasized upon, which has to be followed, which has to be informed to our patients when they get discharged. Infection control nurse plays a very vital role. And let me tell you, in our hospital, my infection control nurse works 24/7. Even when she's on leave, she sits at home and does reporting to the local authorities. So kudos to her for all the efforts that she's doing. She plays a very important role in our hospital. She's the reporting person with who she coordinates with our municipal corporation, and she's a point of contact. So our infection control nurse or the infection control nurse should be involved in surveillance. Surveillance not only of patients that are coming to us, but also about our staffs, which I mentioned earlier. Ongoing training and audits, very, very, very important. Training, and training. On-site monitoring and reporting to local authority. So what can the infection control nurse also do? There's a lot of data that we get. So every month we analyze our data. Okay, what type of patients we got, what age, what comorbidities, if we had death, was it what age group, what were the comorbidities, what gender. So there's a lot of data, a lot of information that we collect from the data that we have with us, and we come up with many good practices, or it's an alert for us how to move on in managing these patients. Now, my topic was role of a nurse in prevention in this pandemic. So it is not just what a nurse administrator can do, which I spoke about, certain administrative controls. It is not just about the bedside nurse, but in our hospital, nurse counselor. Okay, I'm sure that every patient and all of us who have not been patients, we have got a lot of stress. Anytime we do not know whether I'll be the next patient with COVID-19. So in our hospital, and as I mentioned earlier, that we do not allow the family member to be with the patient. It's just by video calling, by video conferencing, that they speak to their family member, and we ensure them the regular updates that go. So just to avoid the stress of our patients, we have established a COVID empathy group. So I personally feel stress has a lot to do with our immunity. So if we are stress free, if we are relaxed, if we are comfortable, it does a lot to improve our immunity. So in our hospital, we have got a COVID empathy group, which is comprising basically of our nurses and doctors who go and meet the patient on a daily basis, just to tell them that we are with you and you are in safe hands. So this is what a nurse counselor can do in reducing the stress of patients. As I mentioned, nurse researcher. So through the infection control nurse or through our nurses working in the COVID wards, we get a lot of information about our patients. So so nurse researcher can do various researches, or the nurses can do many researches just to understand what are the good practices and how we can help patients to overcome this infection. For example, in the previous slide, our speaker spoke about prone position. So, how it helps. So there are many researches which we can do. We just did a research, but of course it was not related to infection control, but we did a research about what is the impact of COVID-19 on the healthcare workers in the ward and the ICU. And we did find, though it was not a great extent of depression, but there were 1-2% of our nurses or our healthcare workers who felt depressed, taking care of our COVID-19 patients. So this is how we as nurse researchers can do researches on various practices and see where we can improve in preventing or curbing the infection. Community health nurse, okay, plays a very vital role. So once a patient goes home, in our hospital, we have got home care home care teleconsultation, which is free of charge. It is not only open for a patient, but any patient who has COVID-19 or who has query is welcome to call, is welcome to call on that particular number and seek certain guidance from the team that we have in our hospital. So the community health nurse, as I said, that whenever a patient gets discharged via WhatsApp, we send the whole brochure about how to take care of home, including your physiotherapy, pulmonary rehabilitation, diet, all precautions that to take. So this is what a community health nurse does beyond the hospital. So it's more of the awareness programs that she can get involved into. Of course, surveillance is another thing. And the same principles or the same precautions that she follows or a nurse has to follow in an inpatient area, the same precautions needs to be followed in the community. So this is how a nurse, whether she's an administrator, whether she's a bedside nurse, whether she's a infection control nurse, nurse counselor, community health nurse, or a nurse researcher, this is all what we as nurses can in our way do to combat this infection and to prevent infection, prevent COVID-19. So I would just like to end my slide. This year, WHO has declared International Year of the Nurse and Midwife. And the Nurses, International Council of Nurses has declared nurses a voice to lead, nursing the world to health. And as I was just preparing this presentation, I thought about our pioneer, that is Florence Nightingale. She took care of the soldiers during the Crimean War. And now we are taking care of our patients who are attacked by COVID-19. So, and I think this is an opportunity for the world to witness the worth of a nurse. So on this, I end my session. Any queries, any questions, you can ask me. Thank you.
Thank you very much, ma'am. You have covered all the aspects of role of a nurse in taking care of COVID patients. I would like to share the participants that Saifee Hospital has cured COVID patients with lowest mortality rate. So that's sure we can, I think lots of effort
yes,
from ma'am.
Yes, we are doing it. Thank you. So how did you get this information? You read?
Oh, huh? We heard a lot, ma'am. So I know that you all are doing great job.
Thank you. Thank you.
Yeah. So there is one question, ma'am. What should be the nurse-patient ratio, ideal nurse-patient ratio while taking care of COVID patient?
Okay. Um, there is no ideal nurse-patient ratio specifically for COVID patients. It is just how in the ICU we may have 1:1 ratio if the patient is critically ill, or 1:2 or 1:3. Because the COVID patients who come to us all need not be on ventilator, all need not be on non-invasive ventilation. There are some who are on high flow mask. So that is the ratio that we can continue to maintain. In the wards, it can be 1:6 to 1:7, just how we maintain a non-COVID area. Of course, what I would like to emphasize is the duty hours. So duty hours is where you need to work on, so that your nurses do not get stressed working for long period of hours, because it is not feasible for them to work continuously in the PP without drinking water, without emptying their bladder. We understand how it is. So that is what we need to take care of.
Okay, ma'am, another question on that.
Yes.
So how many hours per shift for nurses will be the ideal one?
Yeah. See, different hospitals, when this COVID came in, I'm sure we all as nurse leaders also, didn't know what to do, or we didn't have proper guidelines. So it is just by trial and error, which we all have tried, or we have worked on to. In our hospital, preferably maybe to answer your question, it is 6 hours, 6 hours per shift. So in our hospital, what I have done, or what we have done, is we have got 6 hours for morning, 6 hours for afternoon, and for the night we have got 12 hours. But 12 hours is after 5 to 6 hours that nurse docks off completely, takes a break, and then dawns and comes in. So that is how we are practicing. So it is taking care of my, staffing shortage is a worldwide, okay, what you say, cry for nurses. So we need to take care of, this is how we have managed our staffing in our hospital.
Okay, thank you very much, ma'am. It's very nice presentation, and we have learned lots of things. I'm sure that all the participants will gain, and many new things like COVID empathy group and all we have
Yes.
heard for the first time.
I will just tell you one more thing. This nothing to do with infection control. We wear PPs. We wear PPs.
Okay,
So
ma'am.
when a patient sees it in PP, he doesn't know whether it's a nurse or doctor or housekeeping staff. So I do not know whether you can see this. We care for you.
Okay.
So
yes.
this is the sticker which we put on a PP, and they write down the name. The staff or the doctor, they write down the name. So the patient can, identify us through this label that we put on the PP. So there are few, small good things we have tried to put into place to make our patients happy, because you know how it is to be a patient and how it is to be all alone in the midst of all white people around you.
Thank you so much, ma'am. It's really nice. So once again, I thank you, ma'am, and we'll look in future another collaboration with you.
Thank you so much. Thank you
so much, ma'am.
Thank you.
So now we come to the last session. Thank you. I once again thank all the resource person, our excellent speakers for excellent lecture. Thank you again. So I request the participants to kindly leave your feedback form, which is given in the chat box. Please fill it up so that the certificates can be sent to your respective email ID. Thank you. Thank you very much, ma'am.
Thank you. Good night.
Good night. So to organizers, any other questions or any other informations? Okay,
no.
Thank you. So good night, everyone. Thank you for your participation.
Thank you.